My name is Norma Bulamu. I'm a health economist with the CHAP Project based at Flinders University. And this evening we'll be hearing from Mr. Danny Haydon and Dr. Ken Wanguhu from Waikerie Medical Center. As a way of introduction, Mr. Danny Haydon is the principal of the health division at Brentnalls Health. Danny has been a business consultant to the medical and allied health industry since 2008. Danny's comprehensive experience in the health sector means he's committed to building viable medical and allied health practices so they can achieve their goals. Danny has served as a board member and past president of the Australian Association of Practice Management and executive officer at the Clare Medical Center. He's currently a member of the Department of Health Practice Manager Advisory Group. And Dr. Ken Wanguhu is a procedural general practitioner at Waikerie Medical Center. He has worked in the Riverland for the past 20 years after moving with his family from South Africa. Ken has held leadership roles on the boards of Rural Doctors Workforce Agency, River Doctors, and the Rural Faculty of the RSCGP. He has been recognized for his commitment to rural practice, receiving the RSCGP NRF Brian Williams Award for his work in mentoring and supporting other rural GPs. He was also involved in the development of an online cardiac rehabilitation project in South Australia, and his general practice in Waikerie has been and still involved in projects running point of care testing and home monitoring. So this evening, Danny and Ken will be talking to us about Heart Health for Life. It's a program of cardiac rehabilitation led by the rural GPs that is funded by an NHMRC partnership project that is run by Flinders University. So we will start off with Danny talking to us about Heart Health for Life and the business model that we have developed to support rural GPs to be able to run cardiac rehab. And then Ken will be sharing with us his experience in implementing this model in Waikerie Medical Center. So you're welcome, Danny.
Thank you, Norma. It's great to be here with you all tonight. And those of you who know me know that I'm passionate about rural general practice and rural health. And so it's been a pleasure for us through Brentnalls Health to be involved in this very important project, and looking forward to talking to you about the project in this evening's webinar. So just to start off, the CHAP project is a project that both Ken and I have been working with the CHAP team, the project team, to deliver, and we'll explain more about that tonight. Firstly, to explain the acronym CHAP stands for Country Heart Attack Prevention, and so it's looking at heart attack prevention in rural areas. And we know that most rural South Australians, getting access to cardiac rehabilitation is difficult. The tertiary-based options are not often viable, and the rates of rural patients actually completing cardiac rehabilitation is poor, unfortunately. So this project is focused on developing an effective and accessible cardiac rehabilitation models in rural South Australia. So just to provide you with some context, this is the wonderful CHAP management team, as you can see there. You may not know many of the people there, but the CHAP team is led by the very energetic Robin Clark, Professor Robin Clark, and Norma, who's spoken with you as a health economist on the team. The other person who is not in the photo, who you may be familiar with, is Rosie Tiramako, and she is from ICCNet and a lead driver behind ICCNet and the wonderful services that they support to provide support to rural South Australia. As with all research projects, they rely heavily on the partners that are involved. And this slide just gives you a snapshot of the partners that are involved with the CHAP project. So the CHAP project is aiming at putting rural GPs at the heart and centre of the process, because we know that a patient who is post a cardiac event should be able to return to their community and, through the support of their local GP, have access to cardiac rehabilitation programs in their local community. And this project is aiming to facilitate and achieve that for our rural South Australians. So in this diagram, we're going to talk through how the system is designed. If a rural patient is discharged from hospital, so on the left-hand side, you'll see the icons there for a big hospital and a doctor and the computer. So when the patient is discharged from the hospital, post a cardiac event, they'll be referred to the CHAP central referral system. The aim of having a central referral system is to ensure that no one falls through the gaps. So the idea is that everyone who has a cardiac event and needs to be referred for cardiac rehabilitation on discharge from the hospital is referred through to the CHAP central referral system. And that central referral system will liaise then with the patient's local GP to look at the services that will be available to that patient. We can look at the options then of what is available for patients through the model. Firstly, for most, the metropolitan face-to-face services in the larger hospitals is not really an option, as I've said already. There are some country face-to-face services that are based in the larger regional centres of South Australia, but again, that's not accessible to all rural South Australians. The other service that is already on offered through the CHAP program is the CHAP telephone service. So the ICCnet people facilitate access for your rural patients to allied health services via the telephone. So a patient can actually receive their cardiac rehabilitation via telephone through the CHAP program. Up to date, that has been potentially in isolation from their GP being involved. And so the CHAP project has been working on developing the GP hybrid model, in which the patient has the majority of their care organised and coordinated from their GP practice. That could include access to allied health services within the GP practice or within the local community. But it could also be supplemented by allied health services through the CHAP telephone program. So if, for example, in a community, you might have access to a dietitian and a diabetes educator, that would be accessible to that patient, but you don't have access to an exercise physiologist, the patient can access the exercise physiologist service through the CHAP telephone program. And as Norma said, Ken has also been involved in helping to develop the CHAP Web online cardiac rehabilitation program, and that is the final option available here for patients in rural South Australia, that once referred through the CHAP central referral system, they can access the CHAP web-based cardiac rehab program and work through that program in their own time in a way that's convenient for them. But ideally, what we're looking to do is to encourage patients to receive their care through their local GP and to have the services coordinated and wrapped around their local general practice. An important part of the CHAP project is looking to enable rural patients to get access to 4 cardiac health assessments over the first 12 months post their cardiac event, and that these cardiac assessments be conducted by their GP. The idea is that doing that in the general practice, the GP will be able to do the cardiac assessment, but then also to provide the clinical data from that assessment back to the CHAP research team for the important research that they're doing in this project. So as you can see in this diagram, we're looking to have the initial cardiac rehabilitation, the initial cardiac assessment within 1 to 2 weeks of discharge if possible. Then the second assessment would be 8 to 12 weeks post-discharge, the third assessment 6 months post-discharge, and the fourth assessment 12 months post-discharge. So we've found that it made sense in looking to achieve this, to establish the model based on the chronic disease care planning process that is well known to general practices. So our role through Brentnalls Health was to, create the business case for utilising the chronic disease care planning items and to integrate the cardiac assessment into that process so that the involvement of the GP can be cost effective. The services can be wrapped around the cardiac rehabilitation, care planning model that the GPs already know and use, but the cardiac assessments can then be integrated back in, and the information collated can be sent back in through to the CHAP program. So Brentnalls Health investigated the practicalities for implementing a viable and achievable service that supports the CHAP program. We've integrated the Medicare items to support this service and account for it in a cost-effective way for the general practice. We also tapped into a wealth of experience and knowledge from rural practices and in particular practice nurses who are already doing this work in their practice. And the business case has been modelled on integrating the cardiac assessments into the chronic disease care planning process, as I'll show you on this next slide. One of the important things to remember is that when a patient is discharged from hospital post a cardiac event, it is appropriate for the GP to create a new GP management plan and team care arrangement for that patient, even if the patient has had a care plan created within the last 12 months. The discharge from the hospital is an event that triggers and enables a GP to create a new care plan. So in this process that I'll show you here, and we've assumed that the first step in doing the initial cardiac assessment will be coupled with conducting a new GP management plan and team care arrangement, as well as at that time initiating a home medication review that will be billed later. So once that initial care plan has been done, and obviously part of that process is then to refer on and coordinate the team care arrangements with the allied health professionals that will be involved with the care for that patient. The patient would then commence their cardiac rehabilitation. The next step in the process would be within 3 months, after 3 months time for that patient to return for their second assessment. And at that time, the GP will conduct their next part of the assessment. Sorry, that I've skipped a step. Within the 3 months, there would be a second assessment, and at that time, we'd provide that as a standard consultation. but also at that time, the GP would be able to bill for the home medication review if the report has come back from the pharmacist. Then after the 6-month period, the third assessment would be conducted, and the GP would be able to claim for conducting a GP management plan and team care arrangement review item as well. And then following that, after 12 months, the final cardiac assessment would be completed, and the GP could claim for a new GP management plan team care arrangement if that was appropriate, or claim for another set of review items if that was more appropriate. So the business case there shows you that working through all of that process, the practice is able to generate a net value from that of $867 compared to if that patient was coming back to the GP and just having those consultations as a standard consultation, the total value would be just over $238. So the net value to the practice is $629.24 roundabout. We do understand that part of this process is asking the GPs and the practice nurses within that care planning framework to do a little bit more work in terms of the cardiac assessment, but a lot of the elements of the cardiac assessment would be naturally integrated with doing the GP management plan and the team care arrangements as well. The other important part of the CHAP project that we've been looking at is the collection of the data to support the research. We've been concerned that the data collected through the research for the research purposes, and also the data collected through the process of doing the chronic disease care planning may be duplicated. And so we've been working with the CHAP team to look at ways in which all of that information collected can be conveyed through to CHAP without having to duplicate the entry of that data. Now, at this stage, that is still a work in progress and something that the CHAP team is looking to do. We're happy to take some questions on that at the end. So having given you all that background in terms of the project and the business case and how we've sought to deliver that, I'm going to hand over to Ken to talk to you about his experience in delivering cardiac rehabilitation services within his practice at Waikerie. So thank you, Ken.
Thank you very much, Danny. I think I'll start by introducing my team here. I've got Zoe Levick, who's literally our cardiac rehab nurse, and over there, Judy Sparrow, who's our GP. I would call her GP management nurse. She was our practice, our nurse manager until a few months ago, when she's stepped back and is now really managing our GP, our chronic disease management plan. And she has a lot of really lots of experience in this. So I'm hoping people will have questions for the rest of the team as well on how we implement it. As you can see from the plan, they actually do Zoe and Judy do most of the work, and mine is a really brief catch up and just confirming that everything's done, but they make my job a lot easier. So just a little bit about how we started. We realized one of the husband of one of our members of staff had an MI, and when they came back from town, there was no rehab at all, and there was all this information given out in town at Flinders about rehab and the value of rehab, and we'd known this all along. So we then got in touch with Rosie, who, as you've heard, is an absolute magician, and found that we started wondering, how can we address these gaps? And that's how we came up with using GP management plans, team care arrangements to work through this. And we actually eventually went on to develop with Rosie and I then went on to develop an online a web-based a simple rehab plan and that worked really, really well, very fundamental, and we started seeing results, and that's how we developed. So our history has been that, most patients suffer a heart attack or an MI, and it's an acute coronary syndrome or heart failure, transferred to town. They are given 5 days of medication and told, hang around for the next 5 days to make sure your stent doesn't clot. And then after that, head over to your GP. And they would present here without a real plan and without any plan for a rehab. GP appointments are hard to come by, and sometimes they would just fall off. They would be lost to follow up. So by having a formal plan, not just for rehab, but also for follow-up, it has really, really made a big difference. And so we were looking at a method that was sustainable, that could work within general practice, and GP management plans and team care arrangements were the obvious route to take. Because that allowed us referrals to an allied health professionals, and that has really done really, really well. There are also item numbers. In the old days, we even had item numbers for nurses, which of course nowadays are not so easy, but we still have other item numbers that we can use and we apply. The CHAP program has given us a formal way to be notified when a patient has had a cardiac event. We actually get alerted in time, and so if the patient doesn't show up, we will look for them. So we will go out and invite them to make sure that they come in. We believe that the best time to do it is at that time when they have just had the episode, as we would say, hit the iron while it's hot. That's when they are most responsive to plans and feedback. So that's what we try and do very, very much. Obviously, our numbers are not big enough to run group sessions, so it's a really very specialized one-on-one plan. So they'll see Zoe or Judy and then see me or one of the other GPs here, and as soon as they get discharged. So that's what we do. We want to obviously give them the power to manage their own condition and prevent other complications. So really, really good. We have access to exercise physiologists, podiatrists, physiotherapists, mental health as well. We can get all this through the GP management plan. Every once in a while, we find we are struggling with, for example, there's a time we could not access a dietitian at all. And we spoke to Rosie, and we were actually able to organize a dietitian online so that we could actually get our patients reviewed by a dietitian by video conferencing, which works very well. So there are all these sorts of good solutions. I always remember, and I say this respectfully, a little old lady who was admitted very often with multiple comorbidities, diabetic, chronic renal failure, heart failure, and had recurrent admissions for heart failure or ischemic heart disease. And with rehab, getting her into our process and also developing a plan for her, she is unlucky to be admitted once a year. And that's how well it has worked. But that also works with home monitoring, which is not rehab, but is also part of a suite of services that we look at. So with home monitoring, we can tell when her SARS are starting to fall, we can tell when she's starting to put on weight, and we intervene early. So we actually have saved her from being from readmission, and she doesn't remember what angina means. So that's a really good kind of story for us. So really, really quite good. And I don't think I need to, we are familiar, and we haven't yet, despite our best intentions, we have not been able to meet to do all the visits as we would like to, as Danny has suggested. But we do try very much to get the patients in. The problem, obviously, is nursing time and doctor time. That's an issue, and then also compliance. As the patient moves along their journey, they feel better and better, and they forget how terrified they were when they had a heart attack, and they generally do not come back as often as we would like them to. So the multiple visits can be difficult. We sometimes struggle with getting allied health professionals as well. So that's just something that we know that can be difficult. I think the next slide just really just summarizes what we have said. Really, that it's about moving from looking at a healthy heart rather than and keeping healthy rather than waiting until things fall out of hand, and also showing that yes, we can do it with the current item numbers, and as a practice, we are not making a loss. So it's a lot easier for me to talk to my colleagues and convince them that this is how we want to go. And again, like everything else, we really do have, when the GP is in the middle, we get a really good overview of what is happening to the patients, because we know our patients very well. We know their comorbidities, we know their family, we know the issues they struggle with. So again, it works really well, and we try our patients generally. We have realized generally prefer to have a face-to-face, and then the telephone and the web. While you'd expect it to be very popular, our patients tend to be a bit older and not as IT literate. I don't know whether the ladies would like to add something, or if anyone has any questions.
No, I think the home monitoring developing up, if that can go further and be involved as a part of discharge planning with the cardiac patients, I see that as being a real bonus and a good value.
Very good. Sorry, no? Good. Thank you.
Thank you, Ken, for that. It's great to take what we've worked on in theory and to actually talk about it in terms of real circumstances and the benefit that your patients have received from that. And I think that you've demonstrated that through the referral process, you're picking up and making sure that people aren't falling through the gaps and trying to intervene early with your patients, but also then utilising the Medicare items that are available to support your nurses being involved, and then support access through the rest of the team. Before we just finish, we haven't got a lot left to cover. I just think it's probably a good opportunity, maybe if anyone's got any questions, that we're quite open to fielding some questions, especially for Ken in terms of what he's been able to do with his patients. It's open for you just to unmute yourself as you, if you want to ask a question, and please feel free to do so if you have any. Oh, there's quietness there. Ken, I'm just wondering whether I can ask if anyone else who's on the Zoom call have their own experience of delivering similar services in their practices. That's all right. I just thought I'd give you an opportunity if that was the case. So, as Ken said, that language shift from chronic disease to heart health for life is, I think, an important message to take from this. If we're working with our patients, encouraging them to think about heart health for life, and while the business case side of things is focused on that initial 12-month cycle, the idea is for that to continue to cycle on, but to be walking the journey through the rest of the patient's life around their heart health, and looking at opportunities for them to access different services that are available, or different support that's available to improve their heart health. I know one of the initiatives that they have in Clare Medical Centre is that they have a walking group, and one of the nurses takes a group out each week and takes them out as a walking group so that there's an environment for them to go safely and with other people to enjoy walking. And it's amazing that the friendships that have been developed through just that initiative and the support that people have to get out and move a bit more. So just another example of different ways to approach looking at heart health for life.
Cheryl has a question.
Oh.
Hi, I'm Cheryl Wilson. I'm in Barrie. Is there, I might have sort of missed it, are there more services out here in the Riverland or rurally that our patients now have access to? Like, the dietitian, the exercise physiologist, all the stuff that you would normally have in a cardiac rehab program?
Yeah, good question, Cheryl. I think one of the things we know in rural areas, recruitment is particularly challenging, not just for GPs and nurses, but also for allied health. And the model that we've been working on is trying to acknowledge that, and in that if practices have access through locally to a dietitian or a physio, etc., to use those services. But the example that Ken gave was where there was a local failure in the market in terms of not having an allied health service, there is the option to access that via the telephone service through the CHAP program. And they have a large range of allied health professionals who are used to providing telehealth services for rural patients. And so it's I guess it's an accompanying service to the services that are available in your local community.
And with that CATCH program, does that use the Medicare rebates as well with the GP care plan? Because there's only 5, which doesn't go far for exercise physiology, getting someone moving and engaging in changing their eating habits.
Carol, that is really the best part, that if ICCNet organize it, you do not, it doesn't take away from your 5 allied health visits. So that's a really good thing. So very good question.
Excellent. Thank you.
Yeah, so just to reiterate that, the patient will have access to a free service through the CATCH program, and it doesn't rely or take up any of the 5 allied health services that are available to the patient through the care planning process. There are some great questions. Thank you, Cheryl. Has anyone else got any queries while we...
Yeah, there's another question from Sari. She has
Sarah. Excellent.
Hello, my name's Kerry. Actually, I work as a in the CATCH program as a cardiac rehab nurse that works at Murray Bridge, and I offer the face-to-face programs. And we get the same as you, the information advising us that the clients have been discharged from Metro Hospital, and we follow them up the same. And Barrie offers that service as well in the Community Health Riverland Community Health at Barrie. So will this impact on those services, or how does that work?
So Kerry, I'll answer for Waikerie, because that's been and because our problem is obviously that we are not, we do offer the services to our clients, but most of our clients have problems, as you would understand. We don't have public transport. Getting to Barrie can be quite a problem from Waikerie. So it's a 120-kilometer round trip. So they're very reluctant to do that, and that's why it works. But probably for Dr. Wilson, that would probably make a lot of sense. So we do not take away these are patients. We do not, and this our service was actually, we started our online rehab service way even before Barrie came up with this, and so we complement each other rather than take away from each other.
Okay, thank you.
Yeah, thanks, Kerry. I think the where patients can get access to a face-to-face full rehabilitation service, that's an ideal model. And so for the patients that have access through Murray Bridge and Renmark, it's certainly a service that is highly valued. As Ken has explained, is where people have trouble getting there face-to-face that this project is really focusing on. But having said that, I think the other really important part is the work that the CHAP program have done from the outset about referrals post-event, that an important part of the project has been to try and ensure that when rural patients, country patients are discharged from hospital, that every one of them have a referral into the CATCH program. And so in the past, there would be quite a lot of patients who probably live in Renmark or Murray Bridge and those other major centres where they have a face-to-face service, where they may not have been referred on to those face-to-face services. So we're hopeful that through the work that has been done through this project so far, the face-to-face services in the regional centres will be enhanced more through that referral network, but also then patients who are not able to access those face-to-face services have the other options available to them now. Excellent. Thanks.
Thank you.
Thanks, Kerry. That was a great question to ask too, please. Thank you. Sorry. Any other questions before we look to close? Great. All right. So just to reiterate, the business model is really about that heart health for life. There are many item numbers that are currently underutilised in practices. In the work that I do with practices, the review items are not often utilised. The home medication review items are not utilised. And and I know for some rural practices that's because they don't have a pharmacist available to provide that service. But where that pharmacist is available, it's a really important part of the cardiac rehabilitation process for patients to have their medications reviewed, and for that to be connected back into the doctor and the medical record that's on file for that patient within the practice. So utilising those item numbers is really important. Ken also spoke about the utilisation of the nurse items, the 10997 item for the nurse follow-up, and that is one of the most underutilised items in general practices as well. And certainly any time that a patient is coming back in for their cardiac care as per their care plan, the nurses should be able to claim that item as well. I'm sure that your nurses, Ken, are doing so.
Lots.
Yes. So the other part of this model is reiterating this is about the long-term relationship between the GP and their patient. And Ken's highlighted some of the challenge about compliance and getting patients back in for this service, but for some it's particularly important to have that ongoing relationship and supporting patients to keep motivated and accessing the care that they need for their heart health for life. And it's that focus on prevention, wellness, and particular preventing the likelihood of secondary cardiac events, which we know from the stats that if people do not undertake their cardiac rehabilitation, they're at a much higher risk of having a secondary event. So the work that Ken has been doing with his patients has been really important from a prevention point of view, as well as responding to an acute event that has actually occurred. So where to from here? Well, the CHAP program has a lot of work to do still, and is still looking to communicate and work with the rural GPs and practices around the project. If you're interested at all, it would be great for you to contact the CHAP team. The details are there to find out how you can be involved. I know they're looking to recruit resources on to help in the next phase of the CHAP program, and Norma may be able to talk a bit more about that. But the next part is, I guess, the stage where we really need rural general practices to look to get involved and to take advantage of the range of services that have been developed for your patients, and to look to contribute to a really important research project in the collation of the data that you would collect as part of doing those cardiac assessments integrated with your care planning process. So Norma, did you have anything else you wanted to add about that?
Yeah, so in following this up, we would be interested to hear from you if you need any support in us. We will send you a copy of the full report, the business model report, but also we're interested in getting feedback from you once you start to implement the business model in your practice. We'd be interested to know how you're going and your experiences in using the business model and implementing these extra Medicare items into your care plans. With regard to recruiting resources, this may take us a bit of time because we're trying to find resources to be able to do that extra follow-up, to be in touch with you and be able to follow up on how you're going with the implementation. But definitely that's the direction that we are going. And also to look at streamlining the data collection such that it's not a repeat of, such that there's a seamless transfer of data between ICCNet and then what you're doing at the GP practice as well.
Great, thanks, Norma. I think Ken has demonstrated that it's possible to do this, and it's important to do it. So practices can get on board and start the process of looking at what they can do about providing cardiac assessments and rehabilitation within their practices, and look to liaise with the CHAP program and ICCNet through Catch, etc., to get the support that your patients need. So I encourage you to look at, well, what's the first step you can take towards participating in and being able to provide these very important services to support your patients who have had a cardiac event.
Thank you so much, Danny. I don't know if there are any final questions or final comments from anyone.
May I just encourage anyone that really wants to do this to just give Norma a call or give me a call and just talk through any issues. It's nice. It's a massive amount. Reading it is one thing, but actually talking and how to implement it. And ICCNet is always very, very useful, and they will take your call and help you, and they've got really amazing support.
Thank you, Ken. So if there's nothing more, I would like to thank you all for taking your time to be here and to be part of this. And I look forward to hearing from you with regard to the way forward with your different GP practices. Thank you so much, Danny and Ken.